Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, and welcome to the fourth season of Triage, rapid legal lessons for busy healthcare professionals. My name is Lindsey Rogers-Seitz, and I am of counsel in the Research Triangle Park, North Carolina office of K&L Gates. My practice focuses on advising clients on the Stark Law, anti-kickback statute, physician and vendor contracting, as well as working on transactions involving various types of healthcare providers. As we have mentioned in previous episodes of Triage, our healthcare practice group closely monitors various aspects of health law. At the beginning of this year, we compiled a list of topics that we believe will have the greatest impact on healthcare in 2020. In general, 2020 will be a pivotal year for healthcare. First, we are following the 2020 presidential election. Healthcare is the defining issue for a number of candidates and voters in the 2020 campaign, particularly now that the future of the Affordable Care Act, or the ACA, is likely to remain uncertain in 2020. In December, the U.S. Court of Appeals for the Fifth Circuit issued its decision in Texas versus United States regarding the constitutionality of the ACA. The Fifth Circuit held that the ACA's individual mandate to maintain health insurance is unconstitutional because it can no longer be justified under Congress's taxing power after the penalty for failing to comply was set to $0. The Fifth Circuit, however, vacated the district court ruling that required striking down the rest of the ACA. It remanded the case to the district court for a careful analysis as to which provisions of the ACA would have to be struck down with the individual mandate. Several Democratic state attorney generals have since petitioned the Supreme Court to expedite review of the case, with the administration responding that there is no urgency, given that the district court has yet to analyze the pending issues. The debate continues as to whether health care is a fundamental right that should be accessible to all Americans regardless of their circumstances, or it is a choice reserved for individuals who elect to use products and services from private and public sources. Currently, there are 13 Democratic candidates on the ticket, each with their own plan for what the U.S. healthcare system should look like, from Medicare for all and Medicare for more to a public option. Plans vary widely, and it is too early to tell in which direction healthcare will go after the 2020 presidential election. However, healthcare organizations would be wise to assess the impact of these new plans on their business models. K&L Gates will continue to monitor related developments. Meanwhile, President Trump and other legislators continue to make inroads in various areas of the healthcare sector, particularly with regard to healthcare transparency and drug pricing reform. Congress hoped to address both policy priorities as part of the year-end government funding package it passed in December, but the committees with jurisdiction over these areas were not able to reach a compromise among their various proposals. Price transparency will continue to be a focus of the Trump administration heading into 2020. As one method of increasing price transparency, the Department of Health and Human Services, or HHS, released a final rule in November 2019, which requires hospitals to establish and make public an annual list of standard charges for items and services beginning January 1, 2021. Under the final rule, standard charges include the gross charge from the charge master, the discounted cash price, the payer-specific negotiated charge, the de-identified minimum negotiated charge, and the de-identified maximum negotiated charge. At least 300 shoppable services, or those that can be scheduled by a patient in advance, must be displayed in a consumer-friendly manner. Notably, the American Hospital Association, or the AHA, and other hospital groups have filed a lawsuit challenging these requirements as unconstitutional under the First Amendment. Additionally, the administration released a proposed rule in November 2019, which would require certain non-grandfathered health plans to make available out-of-pocket cost information for all covered healthcare items and services through an online self-service tool and, if requested, in paper form. Health plans would be required to make available their negotiated rates with network providers and historical payments of allowed amounts to out-of-network providers. While this proposal is not anticipated to become effect until 1 year after publication of the corresponding final rule, the shift towards price transparency continues to be a focus of government officials and legislators and will likely be a topic discussed throughout the 2020 election season. Also, in an effort to increase transparency, policymakers continue to work on legislation to address what is known as surprise billing, which may occur when a patient receives care from an out-of-network provider or when their health plan fails to pay for covered services. The Senate Health, Education, and Labor Committee and the House Energy and Commerce Committee have announced compromise legislation that would require patients to only pay the in-network cost-sharing amount for out-of-network emergency care for certain ancillary services provided by out-of-network providers at in-network facilities and for out-of-network care provided at in-network facilities without the patient's informed consent. The House Ways and Means Committee and the House Education and Labor Committee are still working on their draft legislative proposals. In addition, Congress continues to work on drug pricing reform. The House of Representatives passed last year House Speaker Nancy Pelosi's drug pricing reform legislation, which the Republican-controlled Senate opposed and the White House threatened to veto. Meanwhile, Senate Finance Committee Chairman Chuck Grassley and Ranking Democrat Ron Wyden continue to gather support for their bipartisan proposal. Among other things, the bill would reduce seniors' Part D coinsurance, require insurers to share pharmacy price concessions with seniors at the point of sale, and require drug makers to pay rebates if they raise prices over the rate of inflation. The inflationary rebates provision has been a point of contention among several Senate and House Republicans who criticize the proposal as an example of government price controls. Policymakers remain hopeful that they can address healthcare transparency and drug pricing reform by May, when a series of Medicare and Medicaid extenders included in the year-end funding package are set to expire. In addition, access to rural health care is a rising problem. Nearly 60 million Americans live in rural areas, yet only 10% of physicians in the U.S. practice in these areas. The expansion of telemedicine, discussed later in this triage, will most likely play an important role. No matter who wins the 2020 presidential election, this issue will remain a priority for Republicans and Democrats alike. In 2018, President Trump signed into law the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment Act, or the SUPPORT Act, which contains wide-ranging provisions that take aim at the entire healthcare continuum of the treatment and prevention of prescription drug abuse disorders. CMS issued its 2019 final rule outlining changes to the physician fee schedule for calendar year 2020, which details several significant changes aimed at addressing the national opioid epidemic and implementing provisions of the SUPPORT Act. The final rule sets forth a new benefit category to allow opioid treatment centers, or OTPs, to bill and receive payment under the Medicare program for medication-assisted treatment, including methadone. The final rule also established bundled payment rates for opioid use disorder treatment services furnished by an OTP and by clinicians in an office-based setting, in order to further increase access to opioid use disorder treatment. Kano Gates is also watching developments on the 340B drug discount program front. In November 2019, CMS finalized the Medicare Outpatient Prospective Payment System, or OPPS, final rule for calendar year 2020. As part of the final rule, CMS finalized its proposal to continue to pay an adjusted amount of average sales price, or ASP, minus 22.5% for 340B drugs under the OPPS. This determination comes amidst an array of uncertainty due to a lawsuit brought by the AHA, along with other hospital groups, against the Secretary of HHS, challenging the adjustment to payment rates from ASP plus 6% to ASP minus 22.5%. The U.S. District Court for the District of Columbia ruled that the Secretary exceeded his authority to adjust the payment rates under the existing statutory framework. CMS disagreed with the District Court's judgment and appealed the ruling to the Court of Appeals for the D.C. Circuit. However, per the OPPS final rule, CMS is collecting survey data and noted that relying on such data could avoid the complexities associated with devising an appropriate remedy. In this regard, CMS appears to be intending to use survey data not only to justify and promulgate a new future reimbursement cut, but potentially also to justify that notwithstanding the district court's decision, no remedy is owed to 340B hospitals for 2018 and 2019. On October 17, 2019, HHS issued two proposed rules that, if finalized, will markedly change the regulatory fraud and abuse landscape for value-based activities. Comments to the proposed rules were due on December 31st, 2019, and a final rule is expected in late 2020. As healthcare providers and payers have moved from fee-for-service to value-based reimbursement, stakeholders have long commented that the restrictions in the Anti-Kickback Statute, or AKS, and the Physician Self-Referral Law, or STARK Law, presented obstacles to innovation in the value-based contracting arena. For example, several AKS safe harbors and compensation arrangements require that financial arrangements be set in advance or not be tied to volume or value of referrals. However, many value-based arrangements, by their nature, cannot be set in advance and necessarily require taking value into account. In response to these concerns, HHS proposed several new safe harbors under the AKS and exceptions to the STARK Law. The proposed exceptions and safe harbors fall on a continuum with greater protections offered as the arrangements involve a greater portion of risk sharing among participants in a value-based enterprise. On the slide, we have identified the exceptions, which range from limited risk share, significant risk share, to full risk share arrangements. A more detailed review of the proposed rule is available on our website. While stakeholders agree that the proposed rules are a step in the right direction, we expect comments will highlight the shortcomings in the proposed rules. For instance, CMS, which issued the proposed STARK rule, and the Office of Inspector General, or OIG, which issued the proposed AKS rule, are not entirely aligned on the definition of arrangements within each category. Because the rules set out detailed requirements, many arrangements will not qualify for protection or may impose additional compliance obligations, such as monitoring. Additionally, HHS decided not to include protections for value-based arrangements based on contracting for the purchase of drugs and excluded various categories of value-based enterprise participants. Kano Gates is also watching the interplay between a Sentinel case from 2019, U.S. ex rel. J. William Bookwalter III, M.D. et al. Versus UPMC et al., and the proposed STARK rule issued by CMS. On September 17, 2019, the U.S. Court of Appeals for the Third Circuit revived 3 whistleblower claims alleging that the University of Pittsburgh Medical Center violated the False Claims Act by billing Medicare for services referred by neurosurgeons in violation of the STARK Law. The court concluded that to meet the standard requiring that compensation vary with or take into account the volume or value of physician referrals, the relators must show that compensation correlates with the volume or value of referrals. Most controversially, the court concluded that any hospital service, technical component, or facility fee billed in connection with the physician's personally performed service counts as a referral. In December, the Third Circuit reversed on the volume or value issue on rehearing. The Third Circuit noted the disagreement about what it means for compensation to vary with the volume or value of referrals and stated that it did not need to decide the meaning of varies with. The Third Circuit found that compensation takes into account referrals if there is a causal relationship between the two, holding that in this case, the suspiciously high compensation suggested causation. In the proposed rule, CMS suggests that only when the mathematical formula used to calculate the amount of the compensation includes as a variable referrals or other business generated, and the amount of the compensation correlates with the number or value of the physician's referrals to or the physician's generation of other business for the entity, is compensation considered to take into account the volume or value of referrals. CMS also reaffirms its prior position, noting that productivity bonuses will not be considered to take into account the volume or value of the physician's referrals solely because corresponding hospital services are billed each time the physician personally performs a service. Also, in the fraud and abuse area, 2019 saw significant government enforcement surrounding marketing and telemedicine arrangements in the durable medical equipment and genetic cancer screening arenas. In fact, the related government takedowns, dubbed Operations Brace Yourself and Double Helix, amounted to 2 of the largest healthcare fraud takedowns in the nation's history. These takedowns involved a range of criminal health fraud and a kickback and conspiracy charges against defendants nationwide, and also involve significant parallel civil investigations involving the False Claims Act. In 2020, we expect the government's heavy scrutiny of telemedicine and marketing arrangements to continue and even expand to the use of telemedicine in other arenas, including pharmaceutical sales and activities. Additionally, as the government continues to be focused on combating the opioid crisis through the work of various government agencies and initiatives, including the enforcement efforts of the Appalachian Regional Prescription Opioid Strike Force, 2020 is likely to be defined by a growing breadth of targets for the government, including physicians and pharmacists who prescribed and dispensed controlled substances. We will also be closely watching how the government may continue to use the False Claims Act as a powerful tool in combating the crisis and holding individuals and companies to account for alleged improper prescribing and dispensing. Finally, as highlighted previously, 2020 may include increased qui tam filings involving physician compensation arrangements in light of the UPMC case. In addition, retail health continues to be an area ripe for growth in 2020 and beyond. As patients are increasingly asking for more convenient and more affordable healthcare options, the industry is responding by adding service options in the retail space, including, for example, the emergence of retail clinics staffed by healthcare providers in local drugstores. Proponents of the retail health model suggest that increased treatment in retail locations may lead to a significant decline in cost of traditional healthcare and may be particularly effective in limiting emergency room visits that could have been prevented if the patient had access to a conventional local clinic. Recent regulatory shifts toward greater interoperability and greater price transparency support the retail model and ease of access to health information and treatment for patients. Further, developing technology and adapting federal and state laws supporting telehealth continues to expand possibilities for innovative healthcare delivery models. Relatedly, K&L Gates fully expects digital health to be at the forefront of an important transformation in 2020. First, the use of artificial intelligence, or AI, is on the rise in the healthcare arena. Its accuracy rates for diagnosing and detecting disease are continuously improving. However, questions remain as to what happens when something goes wrong from a liability perspective. Some commentators suggest that a patient could still sue a physician for malpractice or negligence if the physician makes an incorrect treatment decision, even if such decision was suggested by an AI system. Product liability may also come into play. Due to these open-ended questions, AI is often used as a confirmatory tool, not as a purely diagnostic tool. In 2020, health systems will have to face issues such as training, validation, and implementation practices in order to leverage AI's most beneficial use. Secondly, legislators will be taking a close look at interoperability. Late in 2019, two groups of senators sent letters to HHS urging CMS and the Office of the National Coordinator for Health Information Technology, or ONC, to change its interoperability and information blocking framework as the agencies continue to develop regulations flowing from the 21st Century Cures Act, or the Cures Act. One senator urged CMS to safeguard patient data in its rule that pushes insurers to make records accessible through an application programming interface using the FAST Healthcare Interoperability Resources Standard. Another bipartisan group urged ONC to establish a standard definition for electronic health information in its proposed rule, which lays out exceptions to the Cures Act ban on information blocking. The Health Information Technology Advisory Committee, which was created by the Cures Act, has heard from numerous stakeholders that electronic health information, as defined by the rule, could mean that data not contemplated by the Cures Act could get swept into the rulemaking, thereby extending the government's regulatory reach into fields like pricing, which might not be amenable to such actions. A draft final rule was sent to the White House Office of Management and Budget for review, which is still pending. In 2020, much attention will be paid to final rulemaking. Third, data breaches appear poised to increase in 2020 based on current trends. The proposed rule issued by CMS recognizes the increased cost and need for cybersecurity technology by proposing a new exception to protect certain non-monetary donated technology or services that are necessary and predominantly used to implement, maintain, or reestablish cybersecurity, provided that any donation of services is non-monetary and the donation does not include multi-use technology technology that is not predominantly used for cybersecurity. The proposed exception would require that the donor must not condition the amount of or eligibility for cybersecurity donations on referrals or other business generated by the physician. In addition, the arrangement must be documented in a writing that identifies the parties to the arrangement, the time frame and value of the donations to be made, and further describes the technology and services to be provided over the course of the arrangement. Lastly, we anticipate that most innovative health systems will view telehealth as a standard of care option for primary care virtual consultation. Ultimately, telemedicine will have full regulatory and clinical support and offer a solution to some of the most pressing problems in the healthcare industry by allowing access to cost-effective care. Lastly, over the past 15 years, private equity has made large investments in healthcare, and the results to date have been outperforming the overall market. The role private equity plays in healthcare is only increasing. Organizations should assess their competitive environment, considering the role private equity ventures might play as partners or investors. In addition, the marketplace is seeing increased consolidation among healthcare providers. The days of pure community-based organizations are gone, with multi-state conglomerates oftentimes controlling, including multi-market operators. We anticipate this will only increase in the coming years. In the background, organizations need to be aware of a surge in antitrust enforcement from state attorney generals. We are increasingly seeing state attorney generals taking cues from federal regulators and developing expertise in analyzing and oftentimes prosecuting hospital mergers. Healthcare organizations should analyze the local appetite for hospital mergers in the forefront of any potential negotiation. As I stated earlier, the purpose of this episode is to preview some of the key issues we are following in 2020. Future K&L Gates Triage podcast and client alerts will further analyze these issues as they unfold throughout the year. Thank you for listening and Happy New Year.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.